Luca is a 5-week-old baby boy who is rushed to the emergency department by his anxious parents. For the past 2 weeks, his vomiting has become progressively worse. Now, shortly after every feed, he vomits forcefully across the room. Strangely, moments later, he's hungry again and eagerly wants another feed. The vomitus has always been milky and has never been green. He is now losing weight and producing fewer wet nappies. On examination, he appears dehydrated. The doctor carefully feels his abdomen and discovers a small, firm, olive-shaped lump in the upper abdomen. Blood gas reveals hypochloremia, hypokalemia, and metabolic alkalosis. An urgent abdominal ultrasound confirms the diagnosis of pyloric stenosis. Pyloric stenosis, also known as infantile hypertrophic pyloric stenosis, is the most common surgical cause of vomiting in early infancy, affecting approximately 2 to 5 per 1,000 live births. The exact cause of pyloric stenosis remains unknown, but some risk factors have been identified, including formula feeding, exposure to macrolide antibiotics, a family history of pyloric stenosis, and being firstborn. There are 2 aspects to the pathophysiology of pyloric stenosis: the mechanical obstruction and the metabolic effects. The pylorus is the muscular outlet of the stomach that regulates the passage of chyme into the duodenum. In hypertrophic pyloric stenosis, hypertrophy and hyperplasia of the pyloric muscle progressively narrow the pyloric canal, causing gastric outlet obstruction that manifests as vomiting. The second consequence of pyloric stenosis is the characteristic metabolic disturbance. With persistent vomiting, the infant loses large amounts of hydrogen and chloride ions in gastric secretions, along with associated losses of sodium and potassium. This gives rise to the classic electrolyte abnormality of hypochloremic, hypokalemic metabolic alkalosis. The ongoing loss of fluid and electrolytes also contributes to dehydration and weight loss. Pyloric stenosis typically manifests between 3 and 8 weeks of age. Infants with pyloric stenosis classically present with projectile, non-bilious vomiting. Vomiting may be intermittent or occur after each feeding. A crucial clue is that the vomitus is non-bilious, often milky. This is because the obstruction occurs proximal to the duodenum, preventing bile from entering the vomitus. In about 60% to 80% of infants with pyloric stenosis, a firm olive-shaped mass measuring 1 to 2 centimeters in diameter may be palpable in the right upper quadrant. Ultrasonography has become the standard imaging for diagnosing hypertrophic pyloric stenosis. The classic ultrasound criteria for diagnosis are pyloric muscle thickness greater than 3 mm, pyloric transverse diameter greater than 14 mm, and pyloric length greater than 15 mm. A useful way to remember the ultrasound diagnostic criteria is with the mathematical constant pi, which conveniently sounds like the first syllable of pyloric. Pi is approximately 3.1415, so think a pyloric muscle thickness greater than 3 mm, a transverse diameter greater than 14 mm, and a pyloric length greater than 15 mm strongly suggest hypertrophic pyloric stenosis. Treatment begins with medical stabilization, including rehydration and correction of electrolyte abnormalities. Electrolyte imbalance should be corrected before surgical intervention to reduce the risk of perioperative anesthetic complications. Once the infant is rehydrated, surgery is the next step. The surgical operation is called a Ramstedt Pyloromyotomy, named after Dr. Konrad Ramstedt. It involves splitting the hypertrophied pyloric muscle while leaving the underlying mucosa intact to relieve the obstruction. The surgery can be performed open or laparoscopically, depending on the surgeon. Postoperative care is a continuation of intravenous fluids until the infant tolerates feeding. Feeding can begin 4 to 8 hours after recovery from anesthesia, and most babies are discharged within a day or 2 after the operation. So, as with our patient Luca, Whenever you encounter a 3 to 8 week old infant with progressive, non-bilious projectile vomiting, hunger after vomiting, dehydration, a palpable olive-shaped abdominal mass, and hypochloremic, hypokalemic metabolic alkalosis, think infantile hypertrophic pyloric stenosis until proven otherwise.